to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. L Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is an absolute icon in pain management, a colleague and friend who is really legendary and a person I just cannot ever get enough conversation with. Dr. Forrest Tennant is currently the editor emeritus of Practical Pain Management and was the editor of that publication from 2002 until 2018. As an internal medicine specialist with a focus in addiction, Dr. Tennant set up some of the first methadone clinics in the United States in the 1970s. He has authored more than 100 scientific abstracts and posters and has published more than 200 peer-reviewed journal articles. He is truly an expert in pharmacological addiction and pain management to the extent that the United States government recruited him to oversee the medical forensics of Howard Hughes' death and was also retained successfully to defend Elvis Presley's physician in a criminal trial after Elvis Presley's tragic death. Dr. Tennant has not only served medicine and pain management well for over the last 5 decades, but he has served as a mayor of his city, West Covina, California. He has won awards for his community service in addition to the many that he has been awarded for his medical contributions. He has published many books, a couple that we'll talk about in this episode and the next, and is currently working very hard in the area of adhesive arachnoiditis through his charitable foundation. He is truly a pain management expert with an unbelievable expertise in opioids and their management and shares his incredible insight on that topic today with us. I first met Dr. Tennant at a Pain Week conference in Las Vegas in 2014 where he was lecturing, and I have admired him since and am honored to have him not only as a guest but as a true friend. We had so much to talk about in my conversation with Dr. Tennant, I had to break it into 2 episodes. I really could have done 4 hours if we had the time. I always learn so much when I'm around him. In today's episode, we will discuss how pain management started in the United States, the difference between opioid dependence and addiction, why proper usage of opioids is important, how advancing technology has affected pain management, the strange medical saga of Elvis Presley, Ehlers Danlos disease, the Howard Hughes case, and integrating opioid medications with other medications, and so much more. I know you will enjoy this episode, and I could not have had a better guest than my friend Dr. Forrest Tennant to be the inaugural guest of the Pod of Inquiry. Please enjoy the discussion. I'm here today with Dr. Forrest Tennant, who is an absolute icon in the world of pain management. And I just want to thank you, Forrest, for coming to Georgia and spending a few days with us, working on all of the different projects that you have going on and that I have going on. And the collegiality has been fantastic over the last 10 plus years. I recall meeting you initially at Pain Week, and it's pretty interesting what happens when you get people together who have very common interests. And I know we're going to have a lot of great discussion today. So thanks for coming to Georgia. And I guess to kick things off for our audience that doesn't know who you are, which is pretty hard to believe anybody wouldn't know who you are, but tell us a little bit about how you got to the pain management world and what you've done over the last 5-6 decades.
Well, first off, I'm an internal medicine specialist by trade, served a lot of time in the U.S. Army, and then went from there to the Public Health Service and studied to do primarily research in medical fields. My main interest initially was in addiction medicine, and this goes clear back into the 60s and 70s. And during the 1970s, I was one of the physicians who started setting up alcohol and drug detoxification programs, and later came methadone maintenance. And interestingly enough, this was in Los Angeles, and during the 1970s, when we had these methadone maintenance programs for addicts, and a lot of this was to take care of people who were in Vietnam, we actually had people with intractable pain start coming to methadone programs for addicts. And they came just to get their pain treated. And so from a public health perspective, we said, well, these people have cancer, they have rheumatoid arthritis, they've got other diseases, and they're not addicts, but they've got to have what we called narcotics in those days, now called opioids, but they had to have these opioids for pain treatment.
Well, you were in the methadone clinics, and these patients were coming in for pain, not necessarily to get detoxed off of alcohol or some other drug.
Yeah, right. Well, the way pain management actually started in the United States goes back to these methadone maintenance programs, which were started in the 1970s. And we had people who had severe pain found out that methadone would relieve pain, so they started going to the same clinics that heroin addicts were going to. And of course, this wasn't appropriate. This was oil and water. And so within the county health department structure in Los Angeles, we actually started setting up as far long ago as the 1970s, special units for severe pain patients. And that really was the start of modern day pain management. And it turns out there were a handful of other physicians around the country who had encountered the same thing I had encountered, and that is the rare cancer patient who needed narcotics as well as some medical conditions. And it was considered a rare thing, but there were a handful of us who actually started meeting together in those years. Now, most of us came out of public health and came out of addiction medicine, but we did get pain treatment started, so my clinic actually goes clear back to 1976. So that's how we got started. But I think it's important, even till today, in that we've gone through 2 or 3 generations now of trying to deal with the pain problem. And people don't understand where we've been and where we are now, because it's really quite a positive story. People are getting some help. A lot of advances have been made. It's been controversial because addiction and opioid overdoses have gotten mixed up with legitimate pain treatment, and people seem to know the difference. And media has blurred the whole picture. But we do have today a need for people who have addiction to be treated. And we have a need even today for people who have severe pain to be treated. So that's where we're at today. There's been advances on both sides, both in addiction and both in pain, but they are not the same. And so that's one of my basic messages to everyone. Addiction and pain are not necessarily the same thing.
A lot of pain patients, though, do become addicted, unfortunately, but at least in my experience, we've had a lot of folks with horrible peripheral nerve pain, and they've been on opioids, but once we're able to get their nerve pain resolved, they seem to want to wean off the opioids rather quickly. So is it that some folks are not necessarily truly addicted, but they are just using the medication because that's how they can function, and that's improvement of quality of life?
That's really the difference. No question about it. If you've got severe pain and you've got to start taking morphine or methadone or fentanyl every few hours, you can say you're addicted. I prefer the term therapeutic dependence.
Right.
But those people can stop their opioids if we could get rid of their pain.
Mm-hmm.
But an addict, and I happen to be one that happens to believe that most opioid addiction is genetically based, as well as having cultural and social influences. But those people don't stop. In other words, they don't have a pain problem that can be stopped, and therefore the opioid stopped. They probably, in fact, most of those people, are sad to say, will need to be on an opioid for life. So that's the difference between the two. Yeah, just to look at them and hear they're taking an opioid every 4 hours, you'd think they're all one and the same animal, if you will, but they're quite different.
You made a point in one of your lectures a long time ago that I listened to about how that people who were on fairly high milligram equivalents of morphine per day, but they were completely able to function, and they were not impaired physically because they had titrated up slowly and they were at a functional dose that managed their pain. Clearly, these folks were not seeking some type of euphoric effect from the drug. They just wanted their pain gone.
No, sad to say, but those of us who were old timers figured this out clear back in the 70s, 1970s, that in pain treatment, you didn't start off with opioids. You started off with anti-inflammatory agents, muscle relaxants, exercise. No, you don't want to have anybody take opioids unless you have to. And if you did start opioids, you started at low levels and you titrated up very slowly over weeks, maybe months. And therefore, they could function. They could act like a normal human being. You didn't even know they were taking the drug. They could drive, they could work, take care of their families, and that was the case. Unfortunately, when they made pain the fifth vital sign.
What year was that?
It was about, let's say, right at the turn of the century, 2000.
Okay.
You had drug companies who didn't know better. You had doctors that didn't know better. You had this whole cadre of people in the country who didn't bother to do their homework. And so you had drug companies saying, oh, just go give them whatever they need. You had physicians, you had conferences, professional societies. Forget the proper use of opioids is titration upward, both for addiction and for pain. And they didn't bother to titrate people. So they got overdoses, they got people too dependent. We got way too many opioids used in the country, and so it's been a sad thing. And so the country has paid a penalty for not trying to do the basics of opioid management. They've gone back the people who are left in the pain field pretty well know what they're doing now. We're gotten past this ignorant stage, as I call it. But we did have this terrible problem that led to crises, lawsuits, overdoses. So the country's gone through a real learning curve. And, they frankly didn't listen to those of us who had been in the field for 30 years. We had instant experts in pain management and in opioid therapies who just read a textbook or somebody told them, or they just thought you could deal with these drugs like all the rest of them. But they are dangerous, but they are needed. And so we've seen a tragedy with this, the good, bad, and the ugly, as I call it.
When you first started in pain management, then, it sounds like there were more folks that were really attacking this from the internal medicine, addiction medicine, rather than anesthesiologists that were, pain fellowship trained or physiatrists. Yeah. Those were relatively new, right, in the history of pain management?
Along that line, the timing couldn't have been worse. The timing of jumping into pain management occurred right at the time of great technological advances with the computer, with lasers, with implants, and with electricity. And so we also had come along almost simultaneously with the development of the fentanyl patch and OxyContin, the ability to do epidural injections and implant stimulators and put in morphine pumps, and people thought these were going to save us. They thought that the technology had overcome the basics. They now know it did not overcome the basics. We have people now still in America, we're declining these numbers, but we've had people that have had too many implants, too many procedures, too many implanted things, too many surgical procedures that have been in excess that shouldn't have been done, but everybody thought technology would save the day. Now, let me make it clear. These technological advances have been just that, but they were overused. So today, we're kind of bringing it all back together to where these things are being used appropriately. They're being used for the needy. They're being used by physicians who've had some training. In other words, We had the Johnny and Joni come lately syndrome 20 years ago, but we're over that. And so today, throughout the country, you find pretty well-trained people who know what they're doing. They're using the opioids and the new technologies appropriately. I think we have some issues to where we have poor treatment or no treatment in some parts of the country. But I think in the main, we're really getting somewhere. And I want to get into the fact that the greatest advances in pain management have been that we've developed a lot of new medical and surgical procedures that are keeping people out of having to take opioids and having to deal with heavy-duty pain management. So, put another way, I've been at it for 50 years, and I'll be at it a while longer, I think. We're trying to work ourselves out of a job.
Well, I think the other point that you've made that you didn't explicitly state is that it's great to have all of these technological advances, but there's no one magic bullet. They have to be, assembled or aggregated in, for lack of a better word, a symphony in order to really maximize the patient outcome and patient experience.
You said very well. Let me make it even more simple. The practice of medicine has always been done and will always have to be done by a patient and a family and a good medical practitioner. The three have to always work together. And when you've got these great technological advances, these great drugs, you've still got to put some love and care into it and a little nutrition and some exercises and what we like to call a holistic or integrative approach. This is not new. This is the way it's always been. And I don't care what the advances are. I don't care how many computers or how many robots or how many protocols you have. You still got to have a patient, a family, and a practitioner put it together. And that's the way it's always going to have to be. And today, we just have an awful lot more options, an awful lot more technology. And I think we've lost something here during the COVID pandemic. We have forgotten how to do some basics. But love and care, concern, and good science, good technology, and a good system is still there.
Yeah, that's, one of the things that we like to look at in our preoperative workup with patients is, what's their family support? Is there someone that can be there to help them out that first week after surgery, help them get some meals? All of these things are incredibly important from a surgical outcome because you can do the greatest surgery in the world, but if that person can't eat properly or they stand up too long after a surgery trying to get, food, it undoes what you've done at the time of the operation. So there's also that, but then there's also the support of just having somebody that's a confidant, somebody that you can tell them that you're not feeling well or that you're hurting. And there's a lot of therapeutics in that, at least in our experience.
Well, Steve, you are so right. And not just surgery, but anybody who's seriously ill has got to be in a support system. Another, I call it fault in America today, is that somehow they all think that going to some big center, traveling across the country, is going to solve their problems. Medical care has to be in the family, in the community, at the local level. I don't care whether it's a town of 1,000 people or 10 million. The principles have to be there, and sickness means you're disabled, mentally and physically and socially. And so you've got to have that family, you got to have neighbors, you got to have the church. I don't know where people got the idea that you can just be alone in society and get better. You can't. And I've been sick, you've been sick, everybody's got sick, everybody's going to end up needing some medical help. And if your family's not there and your loved ones are not there, your neighbors, your family, your church, your community isn't all together, you're not going to get well very fast.
No, I don't disagree with you at all with that. I wanted to chat with you a little bit about Ehlers Danlos syndrome, and the segue into talking about Ehlers Danlos was the great book that you wrote about Elvis Presley, the strange medical saga of Elvis Presley. And to all the listeners, I encourage you to get this book. It's on Amazon, and it talks about Forrest's involvement in that case. So Before we get into the disease, let's talk about why you were called into this and then how much medicine you actually learned from analyzing all of this. When Elvis Presley died, it was a very, very big deal. And there was not an airwave in the world that wasn't all over this.
Right. Well, if one goes back in history to about 1976, 1977, as far as I know, I was the only person in the United States who was studying opioids for both intractable pain and addiction. I was studying both, and because I was in public health and had been trained and given grants, and I was studying both. So, first off, when Howard Hughes died, the government asked me to be their medical expert on Howard Hughes because he was found to be taking a lot of narcotics. And so they asked me to be the expert on Howard Hughes and gave me all of his autopsy records and what medical records we had. I appeared in a trial and got to meet his doctors. And so I actually recorded Howard Hughes' medical history also in a book. And a year later, Elvis Presley dies. And of course, he was thought to be just a plain drug addict. And he died at age 42. And there was great controversy as to why he died. Did he overdose on drugs or did he have a heart attack? And there was a trial brought against his physician.
That was Dr. Nick, right?
And they tried to accuse Dr. Nicopoulos of murdering Elvis Presley.
And that was the state of Tennessee. That was not a malpractice trial. That was a criminal trial.
It was brought by the district. The murder case was brought by, they called it wrongful death, but it was brought by the district attorney of Shelby County, which is Memphis. And they tried to prosecute Dr. Nicopoulos, who was Elvis Presley's doctor. Now, Dr. Nicopoulos found a famous attorney to defend him. And his famous attorney was the same attorney that prosecuted Richard Nixon in the Watergate trials. And so you had this powerful attorney and Dr. Nicopoulos, but they needed a medical expert, and they sought me out. And I wasn't hard to find because I was the only one they had. I may not have been any good, but there was no second person. I'm the only person studying opioids for both addiction and pain at the time. And so I appeared in the trials and was given all of Elvis Presley's records, his medical records, his autopsy records, special investigations that were done. And Dr. Nicopoulos was hardly a criminal. Something like 12 doctors at the Baptist Hospital in Memphis had tried to treat Elvis. And they knew he had some bizarre disease, but they couldn't ever figure it out. Well, when the trial was held in 1980 or so, I didn't know what he had either. But we sure knew he was sick. Even his doctors back then knew that Elvis had eye problems, ear troubles, stomach troubles, back troubles. He just had all kinds of serious issues.
Had some head injuries too, didn't he?
Oh, terrible headaches. And one little thing that's really interesting, he wore sunglasses to one of his performances. So that caused all the performers from then on to start wearing sunglasses. But he wore them because he had glaucoma, and he had to wear them. But so a lot of things happened with Elvis. But at the time of his trial, and clear back in the 70s, we had no idea what his disease was. And his doctors, and another thing, both Howard Hughes and Elvis had the best doctors of the day. They were well-to-do people. They could hire the best, and they did hire the best. And the best doctors couldn't figure out what Elvis had, but they sure knew he had something. And they did a lot of tests on Elvis. All the laboratory tests and x-ray tests that were available at that time were done on Elvis, but nothing revealed it. What happened later, which is very interesting, but it really segues into where we're at today, and that is genetic testing. Genetic testing. And at any rate, genetic testing has been able to take chromosomes and to analyze what is wrong with genes and figure out what diseases emanate from these gene abnormalities. Turns out that Elvis did have a genetic disease, and the common name for it today, or the one most usually used, is called Ehlers Danlos. and Ehlers and Danlos were actually physicians who described the disease about a century ago. But that disease is now known to be in existence. We doctors have been kind of hit over the head with it. We didn't know what it was, but we've seen cases for years. We just didn't know why somebody would have this kind of a disease. And what the disease does is cause collagen to disappear. And this collagen keeps your teeth together, keeps your spine together, keeps your intestine together, keeps your eyes together. And if we start losing collagen, you get all these different problems. Elvis Presley had a lot of problems.
So his glaucoma, connective tissue disease, his back issues, probably he had toxic megacolon, or at least a megacolon.
Yes, he had that. It's actually got a fancy name for it, but he had the great big colon and terrible constipation. And it's somewhat unfortunate, but he also was a drug abuser. There's no question about it. That's well documented. How much of that was caused by his genetic need to treat his disease? How much of it was just his psychological state? No one will ever know. But unfortunately, that's what the public sees. They don't really realize how sick the man was. But he did die at age 42, and he died with a terrible heart disease, this connective tissue disease, and he didn't help it with some of his diet and some of his other things. But he died. Most people with Ehlers Danlos syndrome, the severe forms, rarely lived past about age 48. So he was right in the age range that you normally die with this disease. Now today, we know what it is, so treatments are being developed for that particular genetic disease as we talk. And so Ehlers Danlos is now recognized. There's an Ehlers Danlos Society. They're doing wonderful testing to identify these people. Guys like me, I spend a lot of my every day now trying to figure out what do we do about these connective tissue diseases, because they are really out there in society. They say there's about 1 in every 3,500 persons with that disease. Well, if you take 1 in every 3,500 people, we're here in Atlanta, so you take 6 or 8 million people, you end up with a lot of people with that disease. And then if you get something like an autoimmune disease on top of it or something, you're even in worse shape. So this is a new kid on the block. It's being researched. In my opinion, great advances are being progressively made as we talk with that particular disease. Incidentally, anybody who has Ehlers-Danlos syndrome, or what's called a connective tissue disease, would do well to read about Elvis Presley. Personally, I learned more about this disease studying Elvis than I ever did. And I'll tell you one other cute thing about it. I was trying to play the trumpet in a dance band in my high school of Hutchinson, Kansas, when Elvis Presley was at his peak in the 50s. And all us guys thought Elvis was the greatest there was. And so all of us thought that if we could wiggle our hips and shake our legs like Elvis, we could not only play our trumpet better, but we might catch a few more girls.
Yeah.
We were wrong.
Right.
Trying to do what Elvis did, you fell over.
Or you tore something.
He had these loose joints, and that's why he could do these gyrations. And to this day, all of us enjoy watching it. And he was a character. He was very entertaining and a really nice guy. And one last thing about Ehlers Danlos people, they are the nicest people. And I'm not talking just about Elvis, but they tend to have a personality that's almost too nice for their own good, in my opinion. Lovely people, and I think that's part of the syndrome. Unfortunately, they're awful nice people who have a terrible disease.
Yeah, I've had a couple of chronic pain patients with nerve entrapments that we've learned did have Ehlers-Danlos, and they seem to be very stoic. That, you can tell they're suffering a lot, but for some reason they're a little bit more stoic maybe than others. So what happened with the trial? I know that you successfully defended Dr. Nick, but give me a summation of kind of how that went down.
When the jury got the facts, two kinds of facts. One was that not only Dr. Nikopoulos, but all the other doctors not only tried to treat his medical problems, they tried to treat his addiction. They did everything they could to get him off the drugs, put him in rehab at different times, restricted his drugs, and they did everything they could in their power to try to keep him from abusing drugs. And when the jury got this information, it was a no-brainer. They found him not guilty, the doctor not guilty in about a few minutes, actually. So it was, again, a tragic miscarriage of trial, if you will. On the other hand, I can see why at the time, I could see why the district attorney felt he had to do something. There was great political pressure to figure out why this hero of everyone's had all these drugs and what happened. But once they got both the medical facts and the addiction facts, the jury found the doctor not guilty very quickly.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15. Well, let's go back into the Howard Hughes case since you brought that up. Now, the government recruited you to examine the data in that case. Was that more from a prosecution standpoint, or what were you asked to do in Howard Hughes' case?
Well, in Howard Hughes' case, it was pretty much sort of the same thing. But the Howard Hughes medical history has some fascinating aspects to it. Let me relate them in short order.
Okay.
Now, everybody, because of the movie Aviator and other things, thought that Howard Hughes was just a kooky character. Well, he was, because he was born with bona fide genetic obsessive compulsive disease. And the bad decisions this guy made are they're legendary if you read about him or study on him. And one of the terrible things he did was in 1946, he was going to test an experimental plane for the government. Now, this is hard to believe, but he goes up in this plane. Now, he's told this plane has 11 minutes or so of gasoline.
Okay.
And you've got to get this thing off the Santa Monica airport and back onto it in about 6 minutes. So the son of a gun goes ahead and starts flying it way past the gas tank time period, runs out of gas. Plane crashes. He has 11 ribs fractured, lungs collapsed, hips broken. How he ever lived is a miracle. A sergeant saw him, a Marine sergeant, was walking through the neighborhood where he crashed, pulled him out of the plane, and they saved him. And he had a couple of doctors who had been in the war and knew how to save somebody from that kind of trauma. Today, if he'd have crashed, I don't know that a doctor around would know how to do what they did. But they kept him alive long enough to heal him, but he was left in intractable pain the rest of his life. So he had to start his opioids, mainly codeine, and the doctors took care of him. And we could go into it a great deal, but he, after about 1955, he became a recluse for a number of reasons. One was he was quite disfigured. Number 2, he was extremely ill. You saw all these misguided pictures about how he couldn't cut his fingernails or comb his hair or brush his teeth, but we've now seen other patients with this disease. He had what today we would medically call reflex sympathetic dystrophy or chronic regional pain syndrome. And this is a syndrome in which you can't even cut your fingernails or brush your teeth or touch your own skin at times. And therefore, he tried to stay in his hotel room almost naked a lot of the time because he couldn't stand to put on clothes. It hurt too bad.
Yeah.
But interestingly enough, something happened which is kind of a miracle for Howard Hughes. In 1964, a drug came on the market called Valium.
Interesting.
His doctors put him on it. It controlled his obsessive-compulsive disease, controlled a lot of his pain. And so between his codeine and his Valium, all of a sudden he could start thinking again. And he could control his own thoughts. Now by this time, he's 65 years of age. He's so damaged he can't have any kind of a marital relationship or be out in public, but he's still got his mind.
Mm-hmm.
And so what he decides to do is kind of a miracle in itself. And this is the thing I love about the Howard Hughes story. Because he's taken the Valium and controlling his obsessive-compulsive disorder and his pain, he decides to change his life. 65. You heard about changing your life, right?
Right.
We have churches called Change Your Life. Okay.
Right.
Howard Hughes is the epitome of changing your life. He decides to sell his RKO studios in Hollywood, sells TWA, puts all his money in his pocket, and he consciously decides he's going to go to Las Vegas and remake it and turn it from a criminal mafia town into a great entertainment center. Guess what? Been to Vegas lately?
Yes.
Thank Howard Hughes. As a matter of fact, the Howard Hughes Real Estate Company is still centered there, and that company still owns a lot of real estate, still funds the Howard Hughes Medical Institute. But he made a conscious decision thanks to his good medical treatment. Now, there was a trial against his doctors, and I actually appeared on behalf of the government. And because the judge could order in certain documents, at the trial, we were able to analyze the documents and find out he also had doctors who did everything in their power to help him. And so, no, there was no criminal activity, and no, the doctors were the best there were. And Howard Hughes managed to survive. And anybody who's got intractable pain out there ought to hear this. He got his intractable pain in 1946. He lived 30 years taking his medication. And he lived that long on having to take opioids and Valium every day during that 30 years, and accomplished a lot of things in society that we still to this day benefit from. So I guess my message is this. I've written 2 medical history books on these 2 great men because I'm the only one who had the information. And rather than looking at these people negatively, they did a lot being very ill.
Yeah, for sure.
Terrible illnesses. And you just don't get any sicker than these 2 men and accomplish more at the same time. And I can tell you one other thing. They were pretty happy people. Howard Hughes did not die some recluse, unhappy, and I don't think Elvis did either. These guys, they made the best of it, is what I'm saying. So I think people ought to look at him as an inspiration, not as some negative character, and that the people around them loved him and cared for him too. I just hate it that these great people have had such negative image portrayed in the media.
Well, it's real interesting when you have the ability to actually access the medical records and see what really did go on versus the public perception. It can give you a 180-degree different viewpoint, without a doubt.
No question about it. No, I've written these 2 books because I'm the only one who had the records, and I've put the records in the book. So if anybody wants to go look up the Elvis Presley's medical visits to Dr. Nicopolis, they're in the book. You want to know why Howard Hughes died? His autopsy is in the book.
And I believe it was because of the combination of the codeine, and they mixed codeine with something else, didn't they? And that was what gave him the kidney failure?
They had
the
drug that hurt his kidneys was one called phenacetin.
Yeah.
And that also had caffeine in it.
Okay.
But codeine compounded day doesn't have phenacetin in it, mainly because of Howard Hughes.
Interesting. So you mentioned something there that I find very interesting, that by integration of a benzodiazepine with his concurrent opioid management, he was able to become very functional again, and it changed a lot. So I guess my question is, today you get warnings if you have a patient on a benzodiazepine at the same time you give them an opioid. Obviously, there's some discussion we need to have there. But then also the fact that some of the folks that aren't really managed well with just an opioid, but then you integrate a benzodiazepine, all of a sudden now their pain is much more controllable and they actually end up taking less opioid.
Well, I'm so glad you asked this, because my pet gripe today about pain management and about trying to deal with pain issues is that we have hardcore science right now. There's been a lot of researchers in those laboratories in the basements that are working with test tubes and research animals that have really told us how pain works in the brain. But nobody wants to hear about it seems like. And what it turns out is that in the brain, there are about 6 different targets, or if you want to call them targets, we scientifically call them receptors. And these receptors are really action points, and they work by a chemical which we like to call neurotransmitters. And the one probably best known to the public is endorphin, which attaches to this opioid activator or receptor. The second most important one is one called gamma-aminobutyric acid, abbreviated GABA. And what it does, it stops electrical activity in the brain and in the nervous system. And then you have something called dopamine, which acts on it. Marijuana is known to relieve some pain because it has its own receptor called an endocannabinoid receptor. And so in order to get pain relief in a really severe pain, one has to substitute these neurotransmitters. So codeine or oxycodone or methadone is substituting for your endorphins, which the pain is probably depleted. So you've got to substitute. Right. And so the other one that's key is gamma-aminobutyric acid. What is Valium? What is gabapentin? They're derivatives of GABA. Okay?
Right.
And there's a root out there in nature called valerian root. That's why they called it Valium, because this Valium herbal root will give you some similar activity. So in order to get good pain relief and really bad pain, you're going to have to take a GABA agent and an endorphin agent, and you may need a dopamine agent, you may need a cannabinoid agent. And so good pain doctors, and I think we're short on them, have to know that you're going to have a drug in the Valium class plus a drug in the morphine class if you're going to relieve severe pain. Now, Howard Hughes had access to both, and he made it 30 years. Now, FDA and DEA does not restrict doctors from prescribing this or even combining them. They do what's called a black box label. Now, everybody misinterprets this. They didn't say not to use them. They said to be cautious when you're using them. And you should be cautious when you're using them. Now, if you're going to be a doctor and you're going to have to prescribe some Valium or some Xanax, as well as some morphine or Vicodin, yeah, you want to see that patient every month and have them in a good control system and have the family involved and make sure that the patient is safe. It can be dangerous to give these things out. You can abuse these drugs. But in the hands of a good physician or a good medical practitioner, because today we have osteopaths, we have podiatrists, we have nurse practitioners, we have a lot of people who prescribe these things and should prescribe these things. That's what they're for. So what the government has been saying, and the guidelines all say this, be cautious, be careful, but if you got to use them, use them. Today, we've gone too far the other way where people aren't using them when people need them. And so we've now gone from, as you say, rags to more rags.
Right. So what, I think one of the concerns obviously with the opioids is respiratory depression. And, there's a big push now to give everybody, naltrexone in case they take too much and all of this. We'll talk about low dose naltrexone a little bit later, but totally different, areas of discussion. But so as far as a potentiation of drug with an opioid and a benzodiazepine, what's the significance from a respiratory depression standpoint in your opinion?
In the good hands of a good medical practitioner, zero. Now, if you're somebody who a patient just walks in, you take out a prescription pad and give them an opioid and a benzodiazepine all at the same time, expect trouble. Mm-hmm. That's not the way they work. we've known this, goes clear back to 1982. The World Health Organization developed something called the analgesic ladder. What does that mean? You start low, you go slow, you start off at the very lowest dosage you can when you start these drugs. And so what you'd normally do, you'd start off with the weakest opioid out there available today, would be something called tramadol, and then codeine. And then you work up. You don't start right out with oxycodone, for God's sakes, or morphine. You start off with tramadol, and then maybe codeine, and then maybe Vicodin. You go up the ladder. Same way, you want to give somebody Valium, you start off with 2 milligrams, every 4 hours. And then if you need to, go to 5 milligrams. So I don't know why this is so tough.
Yeah.
You start at low dosages and work up. You don't start 2 drugs on the same day. You skip a week or 2 in between them. And when you do simple low-dose titration, it's perfectly safe. There's no respiratory depression. Yeah, if any of us in here decide to go take a handful of Valium and oxycodone today, don't expect to wake up tomorrow.
Right.
No, it's just common sense. And I think what's going on out there is that you have people who are drug addicts, drug abusers are getting a hold of these things, and they're taking them, and then the media blames some physician or some nurse practitioner or somebody that caused this. Now, first off, I know this is asking people to take personal responsibility. There seems to be a disease in the society, no personal responsibility. But those drugs have labels on them. It says take 1 every 4 hours. Didn't say to take 4.
Right.
Didn't say to take 1 every 2 hours. It said to take 1 every 4 hours. I have never seen or heard. Let me repeat this. I have been at this over 50 years. I've testified on dozens of cases, reviewed many more. I have yet to see one case, including Howard Hughes and Elvis Presley, that if a person took the drug as prescribed by the medical practitioner and given by the pharmacy, I've never seen an overdose.
Interesting.
End of discussion. It's time that we start putting some responsibility on the individual to take drugs as prescribed. Now, maybe that's too simple, but if you're not going to take drugs as prescribed, expect overdoses and deaths. And so to start blaming the drug companies, the pharmacists, the doctors, they can't. And recently, we've had some judges now see right through this and are starting to say, no. You doctors and pharmaceutical companies did not cause these problems. People are taking drugs other than as prescribed, or they're getting them from without prescriptions. And if you want to start taking drugs without a prescription and you don't want to take them as prescribed, then expect to die. I mean, I don't know how else to put it. So we've got a real media-driven, lawsuit-driven misperception of what's going on out there. And I can also tell you that there's nothing in any government guideline or labeling by the federal government that's out of line. It's just that nobody likes them or wants to follow them. Mm-hmm. If you follow what the government has done, you're going to be okay. All right. So there's so many myths and misconceptions and blame out there. It's sad.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.